Okay, after a brief break, we can resume this challenging fetal surgery session, one of the most exciting in the last few years. So thank you, Professor Ayman Shaban, for talking about this topic, the diaphragmatic hernia, the prenatal postnatal management of congenital diaphragmatic hernia. I would like to welcome my colleagues in the chairperson, Professor Hani Hamid, Professor Mohammed Mandoua, Professor Ahmed Bassiouni. Thank you, and you all
Thank you. Thank you very much. I'm going to talk today about a topic that's very near and dear to my heart. We have a lot of kids with this disease, and our goal for them is to have a perfect outcome. And some of them do, some of them don't, but we'll talk about it. This is the disease of congenital diaphragmatic hernia. It's a simple hole in the diaphragm during development, or the diaphragm does not develop, and then the organs from the abdomen end up in the chest. They take up space. They take up space from the lungs, take up space from the pulmonary vasculature. They take up space from the heart. And this is a drawing that shows the real disease is that of pulmonary hypertension and lung hypoplasia from the compressive, the mass effect of the herniated viscera, the lung, the liver, the stomach, the intestines, and you can see the impact on the pulmonary vasculature here as well. So it's a simple defect in the diaphragm, but the disease that we're treating is lung hypoplasia and pulmonary hypertension. This pulmonary hypertension is different than other forms of pulmonary hypertension. It's refractory to pulmonary vasodilators. Things like inhaled nitric don't work as well as they do in other diseases. There's a deficiency in surfactant, there's cardiac dysfunction, and a high morbidity and mortality in the patients specifically with severe disease. This is the modern risk stratification protocol that we follow. We get a lot of ultrasounds, we get a lot of MRIs, we try to put all of these together. We use all of them in prognosticating and in determining treatment. Most importantly, the observed to expected lung to head ratio is popularized by Dr. Deprest. This is the observed lung to head ratio measured typically by the trace method. On the right-hand side, you can see the trace method. The machines can calculate the cross-sectional area of the lung at the 4-chamber view of the heart. Divide that by the head circumference, gives you the observed LHR. You can then enter the gestational age into this formula, gives you a calculation for the expected LHR, observed expected ratio, or you can simply go to this website, put your numbers in, and it gives you the numbers, all that you need from perinatology.com. It's very nice. The operation, like I said, it's a straightforward operation. You have a hole in the diaphragm, you have to fix it. So reduce all of the organs. You can see a hole in the diaphragm. Sometimes some anterior diaphragm is left. Sometimes very little diaphragm is left. If you can close it primarily, great. If you can close it with a muscle flap, which is our preferred approach from a transversus abdominis rotated muscle flap for primary closure, that's our preferred approach. If you can't do it that way, you can't close it primarily, we'll put a Gore-Tex patch in, and that's okay as well. The good news for these babies, even though they are born with severe lung hypoplasia, you can see here the liver is herniated, the intestines are herniated, the stomach is herniated, there's ipsilateral lung hypoplasia, contralateral lung hypoplasia, compression on the left side of the heart, pulmonary hypertension. All these things with repair after birth, once you stabilize the baby, you can see how small the lung is there. How tiny, hypoplastic this lung is after repair. But look at a year. The most amazing thing about newborns, about babies, is they continue to grow. Their lungs grow and they continue to grow for the first decade of life. And even the ones with severe disease can have a perfectly normal life if we can get them through the repair and the early phases of life. So the outcomes and the outlook is positive based upon the possibility of lung growth. These are our outcomes for congenital diaphragmatic hernia. For overall, including congenital heart disease, we have an 85% overall survivorship. You can see in the pink. For isolated congenital diaphragmatic hernia, for all patients, 94% survivorship. Our use of ECMO is very low, and our survivorship on ECMO is, you can see it here, comparing these numbers to the benchmark, the national registry we have in the States. But for the patients with severe disease, the outcomes are not so good. Patients with severe disease, less than 25% observed expected lung to head ratio. This is the numbers from the North American Fetal Treatment Network Consortium, 270 patients. Survivorship is only about 40%. All of them require ECMO. And they all are, if they survive, they're in the hospital for at least 6 months, and there's a lot of morbidity, long-term neurologic deficits, delays, other things, and it's a very expensive therapy, very, very expensive. So for severe patients, we have not found the answer. These are the patients that need innovation, they need creativity, they need better choices and better treatments. So severe patients are the ones that we target for therapy. This is where advancements in congenital diaphragmatic hernia are made, with specialized teams that work together, just like the fetal team. The CDH team exists and rounds every day on our patients. We've developed longitudinal care protocols incorporating prenatal to postnatal, better ventilator strategies, better use of pulmonary vasodilators, better nutrition, better sedation. All these things are what makes a big difference in the care of congenital diaphragmatic hernia, and also the possibility of prenatal intervention. In utero repair was the first idea. Mike Harrison and Scott Ezek in 1985 came up with the idea that they would go in utero for severe cases and do the operation inside, do an open fetal surgery and in utero repair. They left the intestines and the organs in a silo and did the repair. They found after 14 cases, they had intraoperative deaths, they had perinatal deaths, and they had an overall survivorship of 29%, while the group that had no fetal surgery had a higher survivorship. This lesson taught us that there are complications that exist with prenatal therapy that limit the effect of prenatal therapy, and that the conventional care is always progressing. The field is always advancing. While you're doing prenatal surgery, the conventional care therapy is advancing. Similarly, later, there came an awareness of some literature from the 1970s that the lung fluid production is important for lung development, and that if you could ligate and put a ligature on the trachea during development, the baby with congenital diaphragmatic hernia would have lung growth, whereas the baby without tracheal ligation would have hypoplastic lungs. This is an example from the lab, the sheep, in which we created CDH at 75 days gestation and did no repair and delivered the baby at term, and this is a bronchogram. Here is a CDH that was created at the same time, littermate, and also had tracheal occlusion 3 weeks later. After 3 weeks of tracheal occlusion, you can see what this does to the lungs. So tracheal occlusion has strong experimental support for reversing lung hypoplasia. Later, in the 1990s, we undertook a series of surgeries in which we did open fetal surgery to place hemoclips, clips on the trachea directly. You can see it here on the right. You can see the clips, 2 clips, one from each side, so that we could remove them and they would cause occlusion in utero. This is the actual operation that we did. This is the fetus that's exposed, the arms, the neck is out. You can see the fetal trachea here behind the vessel loop, and the clips being applied to the trachea. Unfortunately, the survivorship was only about 33%. There was a lot of prematurity, a lot of morbidity. There was 0 survived in the cohort, which showed that this was a better therapy, but the therapy, the outcomes were still very poor, probably because the technique was very was simplistic. Open fetal surgery for a condition that could be treated better by a different idea. So, same thing, the field keeps advancing along the way. Dr. Deprest popularized the use of a balloon tracheal occlusion, using a balloon, a latex balloon that can be placed percutaneously through a local anesthetic or epidural more commonly, and it can be placed in the trachea in late gestation, left in place for 5 or 6 weeks, and then subsequently removed prior to delivery. He and others led the total trial, the randomized trial, of Fetus, both in Europe and in North America. It showed that the outcomes at 6 months, the survivorship was 40% for those that had Fetus, and only 15% that had no Fetus, that had standard care. ECMO usage was also better, 5% versus 29%. And unfortunately, as always, prenatal surgery led to higher rate of preterm complications, both maternal complications and newborn complications. There was no difference in these complications, but the study was very small, and obviously there's going to be more complications with a larger study. So this is an example of how the balloon is placed typically between 28 and 30 weeks. It's that balloon placed in the fetal trachea, and this is just one case. You can see the vocal cords here on the fetal bronchoscopy going into the trachea. You can see the carina, you can see the abnormal carina, the hypoplasia on the left, and then the balloon is coming in. You'll see the balloon placed positioned in the mid-trachea, and then inflated. And then you'll see, we can see through the balloon, make sure we're in a good position above the carina, and then pull the catheter out and leave the balloon in place. Once you're actually in the fetal trachea, this operation will take about 5 minutes to place the balloon. We leave the balloon in place, and then we can follow it and see it very nicely here on ultrasound sequentially. You can see the measurements here. These are very characteristic measurements of the balloon here in the fetal trachea. And you can watch the observed expected lung-to-head ratio go up over time. This is a couple of patients, modest increases in their lung-to-head ratio with balloon removal at 34 weeks gestation, if possible. And the balloon removal is the same, the reverse of the placement. I'm not going to go over it. The challenge here going forward is that the Feto is an advanced therapy, but it has complications. As you saw, the rate of PPROM, preterm labor, complications for the mother, exit procedures, even neonatal death, those risks are real. They are real. And as you saw in the paper, 40% survivorship with Feto compared to, in the States right now, our survivorship without Feto is about 40 to 50%. So when we looked at the North American cohort of the total trial, we found no differences in Feto or no Feto, but it was a very small group of patients. So it's going to be very important as we move forward to think about the risks and the benefits in our centers in North America and your centers here in the Middle East, because there are complications from this therapy. The real advancements that have come in the last 50 years have not been Feto. We don't know what Feto's contribution will be yet. It is still very early. We need to do more cases and have a larger registry. But these are the advances. We have advancements with ECMO, advancements with the permissive hypercapnia, and with longitudinal care protocols. Ultimately, we hope that Feto will be an advancement. So for the future, we hope to confirm the findings of Feto in North American centers, develop the smart balloon. Dr. DePrest is doing this. We were just discussing. He's done several cases avoiding the second procedure. We're using pulmonary vasodilators before birth in investigational work, understanding molecular regulation of fetal lung growth, and continuing to advance conventional newborn CDH care, because that's just it's going to have to be that way long term. Looking forward to the answer to these problems, and I'd be happy to answer any questions at the end. Thank you. I had one more second.
Yeah.
That was good.
Well, yes, we can proceed with the other one, and then we take the questions for both, if you prefer that. Until they get it ready, there's still, we were thinking that the fetal surgery has improved the outcome very much for the diaphragmatic hernia, which doesn't seem to be the case. It's the same thing that happened with the ECMO, when we thought that this have pushed it dramatically to improve, but still it's the survival rate is still almost the same, which is the 50-50 chance. But it seems that with fetal surgery and the tracheal occlusion, it might even get less than the 50-50 chance.
Yes, you know, when we took on new patients for ECMO, we expanded indications for diaphragmatic hernia. Some patients in the past, we would have let them go. We put them on ECMO. So ECMO took on more severe patients, but still the survivorship about 50-50. Same thing with Feto. We are taking on patients that otherwise probably in the past may have been terminated or other things, and may not have come to repair. So it's very difficult to understand the true outcomes in a very small cohort of patients. We need a very large registry. We need a registry that also has comparable survivorship without Feto, similar to what we have in the States and other places. It really needs more study. I think it's just to be cautious. That's all. Not to assume that we're already there.
So do you think there would be some time in the near future that we can detect the 50% survivors, so we don't really give them the risks of fetal surgery, and we just leave them, and then we keep on concentrating on the 50% non-survivors to improve their outcome?
Yeah, you know, I've been doing pediatric surgery and fetal surgery for almost 30 years. And all I see is more sophisticated, more aggressive care. So the answer to that question is I don't think you'll ever see us give less care. I think you will only see us giving more care in the future. That's just my observation. We'll see. Okay. We'll talk a little bit here about fetal lung lesions and thoracic lesions. Um, Primarily, I'll talk about congenital pulmonary airway malformation and bronchopulmonary sequestration, sort of sister lesions, if you will. CPAM is different. It's from a BPS. CPAM is an abnormal cystic tissue of the lung. A BPS is simply normal lung tissue. The difference is that the CPAM has pulmonary arterial and venous drainage, whereas the BPS has pulmonary and possibly or likely systemic vasculature. The CPAM can inflate with air, can fill with amniotic fluid, it has cysts. The BPS does not aerate. The CPAM is completely within the lung parenchyma. BPS can be within the lung parenchyma or can be separate in its own pleural envelope. Unfortunately, there is this thing called a hybrid lesion, which creates a lot of confusion, but it's a mixture of the two, where you have features of cystic lung disease with systemic vasculature. The incidence of CPAM in the United States, because of all the ultrasounds, is roughly 1 in 3,000. Most often in the lower lobes, but can occur in any lobe. Can also occur in 1/4 of the cases in both two lobes, usually right upper and right middle lobe. Some associated anomalies to look for as well. I categorize these simply as type 1, 2, and 3. This is the old categorization. Type 1 primarily has large macrocysts greater than 1 centimeter. You can see it here at operation. It's filled with air compared to the normal lung next to it. The type 3, on the other hand, is microcystic. You can only see the cysts under the microscope, and the tissue is very dense. This tumor here is one actually we took out at an exit. It's very dense. It's like wood, very dense, and it grows very aggressively in the 3rd trimester. So type 1 and type 3, the type 2 is mixed between the two. We risk stratify them in severity by the CAM volume ratio, or CVR. It's a 3-dimensional reconstruction of an ellipsoid, length times the width times the height times 0.52 is the mathematical formula for the volume of an ellipsoid. Divide that by the head circumference, gives you the CAM volume ratio, the CVR. These numbers here, a CAM volume ratio greater than 1.6 is a high rate of hydrops formation. CAM volume ratio less than 1.6 is a low rate. When you take away the dominant cysts, the rate of hydrops is even less, below 1.6. This is an original publication from 20 plus years ago. So CPAM can cause complications, hydrops being the most common or problematic prenatal complication. You can see it here. The fetus has significant scalp edema, has ascites, has a massive lesion in the chest, and it's shifted the heart and compressed the heart significantly. And there's polyhydramnios. After birth, these cysts can then fill with air and trap air, and this can be a real problem when the baby is born. You can see massive air trapping here, and there's no ventilatable lung. The more positive pressure you give, the more air trapping you have, and you have a catastrophe. After birth, we have seen infection, I'm sure you as well. It's infection, chronic infection that can develop here. You can see the pockets of pus here in this lobe. Doing these operations later in life when they developed infections is a real nightmare. And then there's a small, unclear association with carcinogenesis, the pleuropulmonary blastoma, rhabdomyosarcoma, things that can develop in the first decade of life that you would never otherwise see. That risk may be as high as 4%, so it's really unknown. This is our surveillance for prenatally detected CPAMs. Their peak growth is between 21 and 28 weeks, so we tend to follow them closely during that time. If they are small, we follow them less frequently. If they are larger, we follow them more closely. We'll even get an MRI. About 20% of our patients are misdiagnosed with CPAM, and they have a diaphragmatic hernia, and vice versa. With diaphragmatic hernia, they have a CPAM. So for the larger lesions, I'd recommend an MRI some point during gestation. Prenatal treatment, if there is hydrops that develops prenatally and it's untreated, the outcomes are very poor. When I was in training, we used to operate on one of these every week. We did fetal lung resections every week. It was unbelievable. Nowadays, we treat them all with betamethasone whenever they develop hydrops or when the CVR is high, and it's incredibly effective at preventing the hydrops, stabilizing the growth, allowing the baby to grow, and then the lesion becomes less significant from a mass effect perspective. And these are some of the studies. I won't go through it here, but betamethasone for lesions at 1.6 or greater or with hydrops is the standard of care. And it's really eliminated the need for fetal lung resection. Sometimes we have patients with large dominant cysts who develop a significant disease, and these are patients that are probably good candidates for a shunt placement. I'll show you an example in just a second. And then exit procedures for patients with large type 3 lesions later in gestation that are causing significant compression and will likely would not allow the baby to breathe effectively after birth. These are very rare. So prenatal treatment, yes, so as I said, betamethasone, we use needle thoracoscopy and shunt placement for the large lesions. Let's see if I can get this to play here. So large cystic lesions, we will treat, there we go. We'll treat with a shunt, ultrasound-guided shunt. What we have done for the more complicated cases is actually combine fetal thoracoscopy through the same introducer needle, same introducer sheath during it. So here you can see the ultrasound here of a large dominant cyst in the fetus. See the needle coming in. You'll see it puncture into the cyst. Pop, there. And then through that same introducer needle, we can take the trocar out and we can put the camera, and we can actually put the camera and another instrument inside and do diagnostic and therapeutic fetal thoracoscopy through the same introducer needle. Here you can see we're breaking up some septations. Here there's an older shunt that failed. We typically use this technique when there's poor fetal access, poor sonographic windows, and a previous failed shunt. And then we can come out, we can confirm the placement. It's a very nice technique, all with the same introducer needle, and it's under direct vision, which is very helpful. Now, in the rarest cases, we would consider doing exit procedure for congenital, for large lung lesions before birth. These tend to be, by and large, type 3 lesions. And as you image them, you'll see the difference here with these lesions. Rather than being echo bright, they're echo dark. Dark on ultrasound, dark on T2 weighted imaging, where the CPAM is typically very bright. You can see it here in the left chest, a very large, ugly lesion here causing polyhydramnios, causing hydrops, and causing a significant mediastinal shift. And the operation is like any other exit, like you saw before. Typically, the baby is brought out. The upper torso of the baby is brought out while the mother's under general anesthesia, fully asleep, uterine relaxation. We typically don't ventilate the baby to begin with. We may place the endotracheal tube, sew it in place, and leave it without ventilating so we don't change the fetal circulation. Go ahead and proceed with the thoracotomy. Here, standard thoracotomy. You see here usually a 4th intercostal or 5th intercostal space posterolateral thoracotomy. And here's the exposure, a very large lesion. Take the lesion out, sew it up, close the chest, and then begin to ventilate the baby with the endotracheal tube. And then deliver the baby and hand it to these professional neonatologists. Postnatal management for CPAMs, typically we remove all of them unless they're very small, and we start with a CT scan at 8 weeks to identify the lesion. If the patient is symptomatic, we may operate sooner, but most of them have their operations at 3 to 4 months of age by thoracoscopic lobectomy. For sequestrations, the prenatal care pathway is very similar. However, we expect them to grow very little. They typically don't grow very well. The problem is we can't tell the difference always between sequestration and a hybrid lesion, so we're very cautious with these. But most often they don't cause trouble before birth. Sometimes they can cause a pleural effusion because of torsion. You can see this very large pleural effusion in the left chest here, and you can see the sequestration there at the lung base. After birth, we remove these also because of the risk of infection. Typically, again, CAT scan at 3 months of age, and then we'll take them to the operating room, and here's an example of an extralobar sequestration. Not sure if I can, there we go. You can see it has its own pleural covering here, pleural envelope, and the sequestration is inside. This is in the left chest. I'll open up the pleura. These are all 3mm instruments. You can see exposure of the pedicle. The blood supply is inside. Expose the blood supply, put the clips, divide it, and take the sequestration out. Typically, the patient goes home the next day. No chest tube. Everybody is very happy. You have to always watch out for this. These blood vessels can sometimes be very large. These are feeder vessels, systemic feeder vessels that are coming off the aorta. can see how big it is. Sometimes they're coming from the abdominal aorta through the inferior pulmonary ligament, and as you're mobilizing, you can come across these because they're very thin, and you're going to have a real problem as that cut end retracts down deep and the blood's filling the chest. So always beware of feeding vessels and handle them carefully as you're doing the dissection. Intralobar sequestration. Sequestrations can also occur below the diaphragm, above the diaphragm, and even within the diaphragm. And we've seen this not infrequently, a sequestration in the diaphragm, sometimes diagnosed as a neuroblastoma, sometimes diagnosed as something else, but it's just a sequestration. We divide, open the diaphragm, the thoracic side, take the lesion out, cut the vessels, and then close the hole of the diaphragm. The outcomes for these are very good as well. You can see the lesion here, the opening in the diaphragm, and then a simple closure. Lastly, we do not support embolization. Embolization has been reported in the literature, in babies even, to embolize these intralobar sequestration. It's a very bad idea. You can see this poor child here has many attempts, many coils to embolize the vessels, that feeding vessel I just showed you here, with no impact on the lesion at all. So this child, unfortunately, developed thrombosis on both femoral arteries and iliac arteries, had to have a bypass graft done on this child, and still we had to go in and remove the sequestration. So embolization is a very bad idea. If anybody wants to debate that, I'd be happy to discuss it, but it's not a good idea. Thank you very much. Happy to answer any questions.
Any question? Dr. Ayman, there is a question from the floor here.
Thank you so much, Professor Ayman, for such an intriguing talk, actually, for someone to deliver this in a third world country. We still are. I come from the days when my training started with where CDH was considered as an emergency. You would operate in the middle of the night. Aggressive, super aggressive ventilatory strategies and dismal results. And primarily, probably, I think the first breakthrough in understanding such an intriguing pathology was the recognition that the answer to these kids is to wait and employ gentle ventilatory strategies and permissive hypercapnia, and we are all indebted to The Tale of Two Cities, the famous publication series of Toronto and Boston, for that. And then probably came the second era, which is probably, I think, a decade ago, understanding that CDH is primarily a cardiac pathology a priori, rather than just a simple space-occupied lesion that you just put back in the abdomen and the lung will expand. The echoes of the poor intrauterine development are reflected on the heart. And this is the second breakthrough. And the question I have two questions actually. The first is, do you think that we are on the verge of a major breakthrough when it comes to fetoscopic surgeries for these kids? That's number one. And number two, let me jump over the fence to the other side, the parental side. What is the extent or the magnitude of decisional regrets among parents for those who have failed? Yes, understandable, but those who have survived as well your intervention. Thank you so much.
Thank you. It's wonderful. Thank you for the historical perspective. I feel the same way you feel about the advancements in therapy over the years. They have not been surgical, by and large. They've been about delaying surgery, being part of the recovery, as opposed to being a disruptor of that recovery. So delayed repair, waiting 2, 3, sometimes 7, sometimes 2 weeks for the pulmonary hypertension to settle, for the ventilator to stabilize the baby, and for the baby to be ready for an operation, a destabilizing event in that baby's recovery. So absolutely. The question is, whether we're on the verge of a breakthrough with tracheal occlusion. The answer is, I don't think we're on the verge of a breakthrough. I think we're on a continuum of learning. We did tracheal occlusion in 1998 in the laboratory with the balloon. We learned that there was a lot of technical aspects of it that we could not do. We could not keep the balloon in. We could not get the lungs to grow. We abandoned balloon occlusion. Jan de Prest figured that out. He figured it out in a lifelong commitment to this, the technical advancement to allow us to put the balloon in. Now I think we can start to collect data. We can start to understand what are the real risks of fetoscopy, what are the risks of tracheal occlusion, and the physiologic change that the fetus undergoes. Technological advancements with the balloon, changing the design of the balloon to reduce the amount of procedural risk, to make it easier to place, to make it easier to remove. These are the advancements that we'll see in the future here. It's going to have to be technological. Is balloon occlusion going to be the silver bullet to take care of all things? I don't think so. I think we will be adding growth factors, we'll be adding different manipulations, we'll be doing different things 5 and 10 years from now from what we're doing now, no question. But I think it's part of a continuum of knowledge and understanding about lung growth before birth and pulmonary vascular reactivity before birth, and how perhaps tracheal occlusion can improve it. Your second question?
About the parents' decision and regrets and the suffering of a mom with tocolytics, repeat surgery. For those who have survived and made it, and more interesting for those, for those who have demised, but more interesting for those who have survived and ended up having a kid born and surviving.
So, like you, I have been doing this for a long time. I have some of the babies that I put on ECMO 25 years ago who graduated from college, who are getting married, who are scholars, who are athletes. I see those babies. I also see the families for 20 years been taking care of a child who has significant disabilities, neurologic disabilities, tracheostomies, a whole other things. I understand. And while the mother is watching the baby, we're watching the mother. We have to understand that this is the beginning of their life, not the end. When we discharge the patient, it's the beginning. So there is a lot of decision regret. We are studying it in our center. We're studying it from the perspective of prenatal intervention and looking at outcomes long term with surveys to look at that exact question about decision regret.
Actually, I'm just focusing on the, with fetoscopic surgery, you have an additional layer of endurance by the parents, or by the mom actually. Yes. Moms do suffer actually, let alone surgery, etc. But just even the tocolytics that are employed tend to have some really disturbing effects on them.
Absolutely.
Nothing.
Absolutely. I agree with you completely. This needs to be part of the assessment. When we counsel these patients, we counsel them for sometimes 8 to 10 hours over multiple sessions. Who can understand what they're going to start, what they're getting into? Who can understand this? Even the medical students and the residents can't understand what they're getting into when they watch this. It's very difficult for a patient. The question you're asking needs to be addressed. We're trying to address it, whether or not they feel that they are making the right decisions, what information that they received was helpful, truly helpful in making that decision, and what things were not helpful. Great question. Thank you so much.
Thank you so much. Great talk. Thank you.
Thank you, Dr. Sharif. Thank you, Dr. Ayman. And now we are back to our friend, Dr. Carlos Gené from Barcelona, Spain, who is going to talk about pediatric surgery, fetoscopic treatment of neural tube defects.
Thank you again. Let's change to subject. As we have seen, the main problem with the open neural tube defects is the R2, no? As I told you before, the leakage with all the consequences and the direct injury to the neural tissue that is exposed. So we have a hindbrain herniation in almost all of these patients, a hydrocephalus, and need for shunting, and damage of the placode with the disability of the lower extremities and urinary dysfunction and fecal dysfunction as well. So, and we know that this is a progressive condition. It's getting worse during pregnancy and mostly beyond the 34 weeks of gestation. You have seen the wonderful lecture of Professor Abdel Latif. So you know well the postnatal surgeries, and the objective was to stop the leakage and to prevent the further damage of the placode. But the problem we have at that moment is that we have a well-established neurological damage, and in our environment we have a high rate of shunting. So that's the rationale for suggesting some prenatal surgery, right? So in 2011 we had the MOMS trial that proved the benefits of open fetal surgery with this criteria that are being revisited the recent years, and it became the gold standard. And you can do a surgery very similar, almost equal to the surgery that you can offer postnatally to those patients. No? So from that moment on, several groups in Europe and in the States started to wonder what happened with minimally invasive surgery. And at the beginning, these 4 groups started with the fetoscopic procedure, some of them doing that absolutely percutaneous, and some of them, and my center, one of them, doing with the exteriorized uterus. And we developed a technique in 2018, the 2-layer closure you've seen before, and we tried to offer the baby the same operation that in open fashion, but by minimal invasive means, which is sometimes very difficult. So why we prefer the exteriorized uterus to the percutaneous? See these diagrams with exteriorized uterus, the lesion of the membranes is lesser than in the percutaneous, because the center of the instrument in the percutaneous approach is in the abdominal muscle of the mother. So the lesion you do to the membranes and the premature rate maybe worse in these cases. So there are other advantages of the sterilized uterus: less membranes damage. You can suture the membranes to the uterus. You use shorter instruments that gives you some more precision. You can use small cannulas and short cannulas. You can use less CO2 pressure during the intervention, and you can better mobilize the fetus because it's outside. And you can easier monitorize the heart rate. So which are the disadvantages? Of course, you have a maternal laparotomy, and then surgical pain and cosmetic issues. The fetoscopic treatment started in 2006 by the Professor Cole and his team, and they were doing covering the effect with the patch, and they're still doing that. And in 2011, the mom's trial, and then we started to do the fetoscopic approach, first with covering it with a patch, and then with a single layer, and then with the 2 layers technique, and then it was adapted for many other centers in Europe. Some of them are using the percutaneous approach, some of them hybrid, and most of them are doing a 2 or 3 layers reconstruction. So our technique is this one. We approach that hybrid with exteriorized uterus, and we have a plan. We try to do the 2 layers of reconstruction. If we cannot close the myofascial layer, we put a patch on the myofascial layer and close the skin. And if the defect is too wide, we put a patch in the myofascial layer and in the skin. So we sterilize the uterus, and we use 3 cannulas of the 3.3 millimeters, warm CO2 up to 6 to 9 millimeters of mercury, and humidificate the membranes with a humidifier. So this is the team. We have the pediatric surgeons doing the procedure, and the obstetrician doing the fetal positioning. This is the most important part of the intervention, and another obstetrician that takes care of the monitoring of the baby and the mother. So we plan the entrance with ultrasound. We have to repair where is the placenta and where is the best place to put the cannulas to work with the baby. You see here, you see the placenta, we marked it, and then you see here the baby, where is the defect, how's the orientations to put on the cannulas accordingly. And then the dissection. The dissection, we try not to touch the neural tissue and identify the neural roots, and we dissect the neural tissue from the surrounding structures. The funny thing and the nice thing of the fetoscope is that the vision is very nice. You can act very accurate, I think, and you can go inside the cyst. You see that the neural tissue falls down into the vertebral canal. This is another case, and the placenta must remain free and in the vertebral canal. So then it's time to close the myofascial layer. We use a little bit of, we estimate the distance that we need for the patch. We put the patch, a Leoplan patch, it's a dura mater. This is Gore-Tex, is what we used before, to avoid the additions from the neural tissue to the muscle layer that we are going to close. And then normally to reach very well up to 16 millimeters in our experience, and we try to avoid the muscular flaps that are in fashion now. Several groups are doing the muscular flaps. Now we'll talk about that later. You can see several cases, and normally it reaches good. So the muscular flaps. Belfort in Texas Children's Hospital in Houston described, well, is using this kind of flaps that they use the paravertebral muscles to make a muscular flap to cover the defect. But particularly I don't like this technique because you may harm the nerves of these very muscles, and these are very important muscles for those patients which are healthy. This is healthy muscle, and they will need these muscles because many of these patients are going to end in a wheelchair, and it's very important, this musculature. This muscular flaps was described first by Professor Meuli in Switzerland, and then published the technique by the group of Philadelphia in 2015, and many other centers are adopting that. So it's a change in the neurosurgical standard care. You act over a well-functioning muscle that are critical to stabilize the spine, and it's important in patients on wheelchair, and we don't have long-term results yet. So myofascial patch. When we cannot close the myofascial layer, we put the patch. In which cases, wide defect, like this one, or the opposite, this too narrow defect, that the neural tissue will be too compressed into the vertebral canal. So we put a patch on those cases. And we use bovine pericardium. Then, regarding the compression, we checked that in our patients, it's published, and we could see that the technique was not related to the loss of motor level in our patients. So the skin, where normally it's feasible, going to the midline. Sometimes we need some skin flaps in cases of huge defects or myeloschisis, like this one, to allow the skin covering the lesion. So far we did 80 cases. With the open patch and glue, only 7 cases. Then we moved to the fetoscopic treatment with patch and glue, 12 cases. And then with a single layer closure fetoscopically, 10 cases more. And now what we are doing since 2017 is the fetoscopic 2-layer closures. With this patient, we had a 3-layer reconstruction. It was a limited dorsal myeloschisis, another kind of a neural tube defect that we could suture the dura mater as well, along with the myofascial and skin layer. 2-layer reconstruction, 80% of the cases was successful. We had to put the dural patch and the myofascial patch in 7 patients, 2 because it was too wide, and 5 because it was too narrow. And in 2 very severe malformations, we needed to put a myofascial patch and a dermal patch. So these are our results. We have the gestational age at surgery 24.7, fetoscopic time 108 minutes. We have these 3 types of malformations, 21 meningoceles, 19 myeloschisis, and 1 limited dorsal myeloschisis. We had 4 fetal bradycardia, very mild, with 2 injections of atropine were solved. And the gestational age at birth is 35.9. We have a fetal weight of 2.5 kilos. The time to delivery is 10 weeks. We have 3 fetal demise, 2 stillbirths, and 1 termination of pregnancy for bad outcome at the level of hydrocephalus. We had 1 leakage in 1 patient that we discovered 3 weeks after the delivery by ultrasound. It was a very tiny fistula that needed a redo. And we did a redo in 2 other patients with a mild descent of the skin, 43% of vaginal delivery. So regarding the motor level, it was motor level, not anatomical level. We checked this motor level before the surgery and after birth. It was better in 10 cases, same in 15, and worse in 8 in the patients that we control, because we have patients that are born in other cities. And the cerebrospinal shown at 2 years of age is 60%. So the hybrid technique offers critical surgical advantages in our point of view compared to percutaneous surgery. Regardless the approach that may impact the obstetrical outcome, the surgical technique is what we need to compare neurosurgical outcomes, and every defect is different, and the pediatrics and the fetal team should be aware to deal with different options during the intervention. Thank you very much, and I will be glad to take your questions or comments.
Thank you, Dr. Carlos. Any comments? Dr. Sharif?
Thank you, Professor Carlos, for an impressive work. I'm really intrigued by your results. I mean, finally, what I understood that in 1/3 of these patients, after all these, innovations or improvements on your technique, in 1/3, this is 3 of 10, that you are able to say that we have an advantage of going through this long, hard, and probably less traveled road. Again, I would ask you for your point of view from the parents' side of view. The parents, what do they think? Yeah, I mean, from your results, I could see that 30% have improved, definite improvements by your standards of assessment of pre and post motor levels. But, I mean, the rest have a quarter, I think, have got worsened, and the remaining were the same. Regarding the whole coast, and again, this long journey, is it justifiable for a lot of parents or not? I'm not attacking this, but I just want to know, how do they think about this?
Yes, it's a very good question indeed. Thank you very much. We are very happy about the motor results, because before we compared the anatomical level to the motor level only, and we have proven that there's nothing to do. So the first that started to check for the motor level before surgery and after birth is our team. So these are the first results we have regarding the motor level, the differences. And it's a progressive malformation. So you say 1/3 has worsened one level of motor level, but the other 2/3 have the same or have improved the motor level. For us, this is a huge success. There are other things that bother me more. For instance, the urological function. It's impaired in almost 100% of these patients, regardless of what you're doing. The fecal function, the bowel function is impaired as well. But from the motor level point of view, we are very happy because we know the difference, and the rehab people from our hospital is very happy because they know the difference comparing to the patients which are not having this surgery. So, but we don't have the comparison with the non-operated people. You understand what I mean?
Ask you how do you assess the motor level in utero, so I'm just I'm taking your words for that.
I appreciate the question very much, but we are very happy in this. We are not happy in other areas. We're having a significant rate of inclusion dermal cysts that need to be reoperated in 3 years' time, 4 years' time. We're having bad urological outcome. These are the things that bother us a lot. But the motor function, we are frankly happy.
So there is a definite advantage then, at least.
Yeah.
And in one domain, that's great. Thank you.
Thank you.
Any other comments? Thank you, Dr. Carlos.
Thank you.
Okay. Now we move to the next topic, pediatric surgery, neonatal anorectal malformation by Professor Dr. Amr Zaki, Professor of Pediatric Surgery, Ain Shams University.
Good afternoon, my colleagues. This presentation is about types and classifications of anorectal anomalies. Anorectal anomalies represent a diverse spectrum with different expression in the male and female. Not uncommonly, anorectal anomalies are associated with other congenital anomalies and syndromes. Over successive years, there were several classifications based on embryological, radiological, as well as clinical observations. This is the old terminology which refers as imperforate anus, referring to this newborn born without anal opening. The inversion radiography is performed to assess the position of the rectum in relation to the perineum, whether it's a low anomaly where the rectum is near the perineum, or it's on the right hand side, it's a high anomaly, and in between we can find an intermediate type. For a low anomaly, as you can see here, the air in the rectum is very close to the perineum. We can confirm this at operation by aspiration of meconium from the site of the anus, and this is treated by simple anoplasty without a need for colostomy. On the other hand, a high rectum, as you can see in this X-ray, will be treated in the neonatal period by colostomy, and the baby will be discharged for reconstruction later on. More recently, we have been adopting some of the high types or the intermediate types. We can go straight forward for primary posterior sagittal anorectoplasty in the neonatal period and save these newborns from colostomy. But of course, here the level of the rectum should be matched by the experience of the surgeon. In 2005, experts from all over the world gathered in Germany, and they had published the Krickenbeck classification that had exchanged the old classification of low, intermediate, and high, which was common, to a new classification depending on the types, which describes the rectal termination. Usually in more than 90% the rectum doesn't end blindly, but it communicates with the urogenital tract anteriorly. So according to this level of communication, whether it's rectourethral, rectovesical, cloacal anomalies, and other rare types. So starting in the male, this is at one end of the spectrum. The minor forms in the male is a rectovarineal fistula or anus. As you can see, the anal opening is displaced anteriorly in comparison to the control, normal control. Usually it's not called an anus because it's usually narrow caliber and not exactly in the center of the sphincter, as shown here by the muscle stimulation. At our department, we had the opportunity to study these cases extensively with collaboration with pediatric radiologists using MRI to define the anatomy in these minor forms and the exact deviation from the normal anatomy. It's not only the slight deviation at the surface, it's also there is a deviation of the anal canal at deeper levels, and you can see here in comparison to the control, the anal canal is narrow, elongated, and the muscles are crowded behind the anterior displaced anal canal. clinically, there are maybe different forms. Usually, these minor forms can be corrected by a simple cutback anoplasty. For those who underwent colostomy at birth, the child grows and returns for the definitive repair. The colostomy have another function. We can inject contrast through the distal colostomy, which help us to clearly identify the level of the rectum and its communication anteriorly with the urinary tract, as in these three different cases, the rectobulbar communicating with the prostatic urethra, and also the right-hand side communicating with the bladder neck. In about 10% of cases, this is a true imperforate anus without fistula, and this represents a minority of cases of anorectal anomalies. This is the standard posterior sagittal anorectoplasty. We start by marking the site of the anal canal according to the striated sphincter complex. We open in the midline, open the pelvic floor, the levator ani, dissect the rectum, and finally we do the anoplasty. This is at the other end of the spectrum in the male. The more severe types are the rectovesical fistula. Usually they are associated with other syndromes like the caudal regression syndrome, dysplastic sacrum and hypoplastic sacrum, flat buttocks, and usually they have poorer prognosis for continence. Shifting to the anorectal anomalies in the female, the condition in the female is usually can be diagnosed on clinical examination by identifying the three openings, the urethra, the vagina, and the rectal termination in the perineum in the left-hand side, while in the right side we can see that the rectal termination is inside the vestibule, but still we can identify three separate openings. These are variants of the rectovestibular fistula or anus, and there is getting more severe forms to reach the rectovaginal fistula. Here, on the number A, we can see that the rectal opening is inside the vagina, is shifted inside the vagina, and then we can see only here two openings in the perineum, and then the other end of severe end of the spectrum, we come to the cloacal anomalies, where the urethra, vagina, and rectum join to form a single opening in the perineum. Also, we had studied these cases, cloacal anomalies, extensively, trying to benefit from the multiplanar capabilities of the MRI and its high soft tissue resolution to study associated Mullerian anomalies, which are common with about 40% in cases of cloaca. This case showing the distended urinary bladder, two hemivaginas, and a longitudinal septum in between. Down we can see here the skeletal muscles, the striated muscles of the sphincter with no rectum or anal canal inside. Another variant of the cloacal anomalies is the posterior cloaca. Here, absent external genitalia in this female, and the urethra and the vagina open conjointly in the anal canal. One of the syndromes which is known to associate anorectal anomalies is the Corarino triad. This is a rare syndrome. However, it is characteristic with some types of anorectal anomalies. This is the anal stenosis or the funnel anus. In the mid X-ray, we can see sacral defect, a sacral notch, marking for a presacral mass, usually a lipoma or a lipomyelin or a dermoid cyst. This is more complex forms of the anomaly, which are associated with anorectal anomalies as well, is the caudal duplication syndromes, duplication of the external genitalia and the colon and the rectum. And Next is one of the fascinating conditions in pediatric surgery, the conjoined twins. The anorectal anomalies are also maybe included in these forms where there is pelvic fusion. Pelvic fusion between twins may be dorsal fusion, as in this case, which is the bigobigus. Over the last 15 years, we at our department we have successfully separated 2 pairs of this type of twins, which are essentially fused at the sacrum and the perineum with a single anal canal. The ventral fusion is even more complex. This case was referred to our university hospitals from another country. It was abdominal and pelvic fusion, omphaloischiobaigus. This represented was a good example for a teamwork where different departments have collaborated to manage these cases, this pair of twins, and it took about 20 months to prepare complete investigations, study the anatomy, the abnormal anatomy, and insert tissue expanders. And finally, this was a successful teamwork. Multiple surgical departments shared in their separation. To come to the conclusion of this presentation, the anatomy of the pelvis is one of the most complex regions in the body. Anorectal anomalies present a spectrum of deviations from the norm which may be difficult to perceive through surgical practice alone, and the advent of cross-sectional imaging has provided a powerful tool to study the spectrum of the anomalies in deep and multiple planes. Thank you very much.
Okay, thank you, sir. Very interesting, especially about conjoined twins. Yes, very good job. And now we're left with Professor Muhammad Qutb. Dr. Suefi, Professor, there is a last session about practice and experience pediatric urologist. Okay. Yes, we could start, sir.
Good afternoon. I'm Muhammad Qutb, Assistant Professor of Urology, Ain Shams University. Our target today is just to give a very brief presentation about some tips and tricks for pediatric urologists. Our target today will be a pediatric laparoscopy. What are the best technique for pediatric laparoscopy? Back pressure, not always the problem. We should give a brief presentation about that. Some tricks about posterior urethral valve, antenatal hydronephrosis, and tissue transfer are the best substitutes for urethral stricture, and take-home message. Actually, our presentation will be focusing on pediatric laparoscopy. So, laparoscopy for young children, tips and tricks. It just goes into the time schedule will be pediatric laparoscopy has been first described in 1923, but actually it gained acceptance by its use in diagnosis of. So it's just a brief presentation about tips and tricks for pediatric laparoscopy. Actually, what is the best age for pediatric laparoscopy? I think this is a question without an answer, but the best age for pediatric laparoscopy will be related to the patient weight and the patient size, not the actual patient age. Here's the introduction, shows that the acceptance of pediatric laparoscopy depends on its use in diagnosis for non-palpable testes. It's gaining acceptance in its use in diagnosis of non-palpable testes. Laparoscopy followed by robotic assisted laparoscopic technique, and it actually uses the same principles of laparoscopic surgery. So what implies for laparoscopy is the same principles for robotic assisted laparoscopic surgery. It expands, of course, nowadays. Its use includes a lot of techniques, but laparoscopic possibilities are limited only by imagination and technology, taking into consideration that the child is not a small adult. It's not only a small, he is not only a small adult. Pediatric laparoscopy, again, is not just the use of smaller instruments. We need some better manipulation for the tissues, better techniques for the pediatric age group. Why minimally invasive surgery now become more popular in pediatrics? Actually, you've got a lot of causes, but this includes procedure-driven, as it succeeded already in adults. Most of the techniques we are using already succeeded for the adults. That's why we are trying to replicate the same success for the pediatric age group. Parent and patient driven, because it's famous that it's better to do it by minimally invasive procedure, but again we should say that this is not the rule for all patients in the pediatric age group. Technology driven, of course, smaller instruments, better visualization, and the advancements of the technology for hemostasis and suturing make it easier to do it by minimally invasive procedure. Surgeon driven, of course, it's career advancement, and it's the advancement of the technology doing it by minimally invasive surgery. There is a lot of anesthetic considerations, and this is because this is the general principles for anesthesia for a young child. Actually, I will pass the anesthetic considerations, but we should say that we got a small abdomen, so we will get high intra-abdominal pressure. That's why we saying that there is some rules to decrease the intra-abdominal pressure while doing the insufflation. Other considerations for the respiratory and GIT considerations increases the risk with the increased risk of regurgitation and coagulation system with increased venous stasis. Common surgical considerations should be considered for adults and for the pediatric age group. Open techniques for the pediatric age group, of course, it's much better to use open technique or Hassan's technique preferred over Verra's needle. And in infants with low weight, less than 5 kilograms, it's better to avoid the peri-umbilical area because sometimes we got a patent umbilical vessels. And of course, after tracheal intubation, we should use the orogastric tube and the bladder catheterization in order to get better space doing our procedure. Common laparoscopic advantages for all laparoscopic techniques, it includes common laparoscopic benefits, magnification, and of course better magnification leads to better hemostasis, open technique replication. Whatever we can do by open surgery, we can replicate it and do it again by minimally invasive surgery. And new instrument invention, of course, with a steeping curve of experience and improving experience and equal oncologic outcome. Common laparoscopic benefits, as any laparoscopic or minimally invasive surgery, it includes short hospital stay, rapid convalescence, decreased pain, and at last, better cosmosis. It's not our target, but of course, we get a better cosmosis. Magnification, we can get a better magnification, and of course, better magnification causes better hemostasis. If you can see, this is an example of the artery and the vein. In all, these are 2 centimeter structure, and it could be shown in all of this picture. Better hemostasis, of course, and open technique replication. We should replicate the technique with the same success as open surgery. New instruments includes better instruments for suturing and better instruments for hemostasis. Of course, the laparoscopic experience is not similar to robotic experience. It's much more, maybe more difficult, but actually we got a steeping curve, but after gaining experience, so it's easier to do the job. Special pediatric techniques, as we said, the anesthesia and patient criteria, instruments and port, access and inflation and technique. Anesthesia, we said as before, and safety of laparoscopic procedures have been documented in even complicated pediatric cases. Of course, we got a lot of instruments for the pediatric,